Welcome everyone. I would like to present my progress since August. Sorry for being a little late. The subject of my thesis is functional and morphological investigation of complex coronary pathologies, recent modalities. I have 4 projects from which 2 are considered ready. Let me begin with the first one. This is the protocol publication of our multi-center randomized controlled trial, RAFE, which means radial artery puncture hemostasis evaluation. It was published in the Frontiers in Cardiovascular Medicine, so we moved on to our further projects. The second is the meta-analysis, which is drug-coated balloon effectivity in the treatment of early and late drug-eluting stent in-stent restenosis. This is also submitted since 5th of October, and since then they asked us to suggest some reviewers. We did that, and review is ongoing actually, so we are keen to see some reports about this to have our changes if needed. The third one is the open ISR. This is the optimal treatment for coronary in-stent restenosis. This is also a protocol publication of a multi-center randomized controlled trial, which is already running. We started this in May, and yeah, we had some late in the publication of this, but it's actually ongoing. So the background for it is that coronary heart disease affects approximately more than 100 million people worldwide. And in Hungary, it's responsible for 35% of deaths. And the most advanced therapy currently is drug-eluting stent implantation. And though these implanted stents the eluted drug of them is protecting from in-stent restenosis, about in 10% of the cases it's still observed. And there is no decision currently about the optimal treatment strategy of these lesions. Mainly 2 treatment options are available: new layer of drug-eluting stent and drug-coated balloon. And drug-coated balloon could be a future direction because it doesn't come with further elevated risk of in-stent restenosis or stent thrombosis. It might be not as effective in early DRESS ISR, which is described that earlier than 12 months after the index procedure, than in late DRESS ISR, which is described as more than 12 months after the index procedure, the clinical symptoms arrive. Our aim was to decrease the need of recurrent revascularization. We developed PICO, which generated a question that does the new generation paclitaxel and sirolimus-coated balloons perform as good as the currently used 3rd generation drug-eluting stents? And we included all patients presenting with DRESS ISR for PCI. We had the intervention arm that sirolimus or paclitaxel-coated balloons, and its control new generation of drug-eluting stents. And the outcomes, which are late lumen loss, and which is our primary outcome currently, and secondary outcomes, which is a device-oriented composite endpoint, which is target vessel myocardial infarction, target lesion revascularization, and different optical coherence tomography measured parameters. Our hypothesis was that the novel drug-coated balloons perform as good as the 3rd generation drug-eluting stent. So we would like to aid clinicians in choosing the correct equipment for reducing complications and improve patient outcomes. So we drafted a protocol, and recently that the writing of this paper did get to an advanced stage, we needed to rethink our patient number. Would it be enough? Because it's very hard to do our own. However, we have 2 other centers. One is Debrecen and one is Szeged, to get involved some patients. But to power a clinical trial like this, we would need, as our current calculations about the literature, currently probably 5,000 patients, which is not makeable. I did a little literature search, and I found out that there are articles which are describing that late lumen loss is a good predictor of drug-eluting stent effectiveness, and this was an earlier published article from 2005, but actually they did a meta-analysis about this in 2018, which also generates evidence about that the new generation of drug-eluting stents, however, come with less drug-eluting stent in-stent restenosis, but bigger late lumen loss than 0.50 millimeter is still a good predictor of the effectiveness of these stents. So we moved our device-oriented complex endpoint to be a secondary one. So the protocol is as this: one arm sirolimus drug-eluting balloon, one paclitaxel drug-eluting balloon, and the third is the everolimus eluting stent. And the patient gets randomized, then the treatment, and after 6 months we assess our results. There are 10–20% of patients who get also optical coherence tomography measurements just to get more information about these lesions. We measure endothelium thickness and strat coverage also with them. So the manuscript is actually almost ready. We are waiting for the statistical input, and then we actually can submit it. Probably we'll try the third time frontiers also. Let's see. And we also started a fourth project, which is another systematic review and meta-analysis, which is conventional versus facilitated hemostatic dressings after radial artery puncture, or systematic review and meta-analysis. You may be familiar with this subject because we already have our randomized controlled trial, but actually, as seeing through the evidence, there is no meta-analysis about these devices. So the number of studies are limited, but still it would be a new one which could show some stronger evidence than it is actually. So basically, we have the theory that during invasive diagnostics, coronary angiography, and PCIs, where the radial artery puncture is the gold standard puncture site, it is very important to have good hemostasis after removing the sheet to get the complication number as low as possible. It is low, it's about 5%, but still it could be lower, and as it's performed in big numbers, every percent counts in this subject. So we developed the question: if the newer facilitated hemostatic dressings are performing better regarding radial artery occlusion, radial artery damage, local bleeding events than the conventional mechanical compression devices. So we include patients after radial artery puncture presenting for angiography or intervention. The novel facilitated hemostatic dressings are the intervention arm, and the conventional mechanical compression devices are the control arm. And radial artery occlusion, radial artery damage, and local hematoma bleeding events will be assessed. And we hypothesized that facilitated hemostatic dressings are performing better than conventional mechanical compression devices. So we did the Prospero registration of this. The systematic search article selection is completed. We have right now 8 trials, and we are on the way to extract our data with our students. And I would like to do in the next month to getting the second article accepted, submit the third article, and finish data extraction on the fourth project. Thank you very much.
Early and late in-stent restenosis is a major issue. And while you are trying to compare these patients and these events, how do you take into consideration the patient characteristics and how often the doctor is seeing these patients and controlling their medications after the intervention?
So it is a very complicated subject because there are a lot of interesting and very, very diverse risk factors to develop an in-stent restenosis. And we are doing it to have one more information about these patients, because nowadays, as the intravascular imaging is on the rise, but still not financially dealt with in Hungary, at least, and of course also in Europe, because one examination could be like 4,000 euros, and it cannot be done by every patient presenting for in-stent restenosis. It could be one more information to know because of the different characteristics of early and late ISR, which is proven by randomized controlled trials using optical coherence tomography and intravascular ultrasound. We could get, without looking into the vessel, this information, how the plaque will react to therapy with a drug-coated balloon. Of course, when it's not enough, you can see on an angiography also, then you move to a stent implantation or other more aggressive therapies. But basically, of course, that would be so much more expensive, because also which cannot be financially dealt with in Hungary, that it is one good factor to consider, that the early one is which is more aggressive, of course, that's why it comes so early, is better reacting on a new layer of drug-eluting stent. Did I answer your question?
Yes, to some degree, yes. I have another one.
Okay.
Can you say something about potential gender issues here? So this restenosis, does it happen more or at least frequently in women as compared to men?
That's a very good question. I remember one study which said that it may happen more in women, but actually no strong evidence which we found consider this measure in big numbers to have significant evidence and patient number on it.
Thank you very much.
Provocative question. How the drug elutes from the balloon? What is the mechanism and what is the penetration rate toward the plaque? How does it work?
How does it work? Okay.
If I insert it into the bloodstream, will it elute the drug immediately, or just after giving some kind of pressure, inflating the balloon, and then it releases? How it works?
Yeah, thank you very much for the question. It's these balloons are like normal semi-compliant balloons, which on the semi-compliant balloon design, and they are inflated with less pressures than normal semi-compliant balloons or non-compliant balloons, like 4-6 atmospheres mostly. And then it needs to be inflated for 1 minute at least. It says the more it's better, of course, but 1 minute it's tolerable for the patient and effective for the drug. So there is a difference between the sirolimus and the paclitaxel-eluting balloons, because there were no technology earlier to have the ability to use limus drugs on these balloons. It was developed recently, so it's a new technology actually. The paclitaxel-coated balloon is already there since like 20 years. However, just interesting thing that not in the US, as I currently know, it's still not approved, or it's in the working, but they really don't use it. But in Europe, there is like for more than 10 years, it's available. And it is also used with different dextrane material to get well into the cell and have the effects to inhibit the tissue proliferation and to develop, of course, the neointima proliferation, which is the factor it can affect, not the neoatherosclerosis, which is happening naturally.